Thank you very much. From a big artery disease, we move down to small artery disease. I disclose that I do consult for lymph flow and inari. So the title of the talk was Case Selection. What are the kind of cases that you want to do a TDAV or venous arterialization? These are possible cases. For those who are not familiar, venous arterialization is used for patients with small artery disease, no obstructive cranial ischemia. These are possible cases. These are the cases you do not want to do, as venous arterialization takes some time for vessel remodeling and for soft tissue to heal. Cases in the heel generally not recommended, but I must say we have had some interesting experiences with healing these wounds. Angiographically, good candidates are those that where you cross from the artery to the vein, you don't compromise the existing collateral. So possible locations to cross are over here. Generally speaking, we don't do the anterior circulation. Poor candidates are those with inflow disease, those who do not have no option status. So these are the patients that you would treat with other modalities. Poor candidates, extensive inflow disease, as I mentioned, having the peroneal as a single vessel. You don't want to cross from a peroneal artery to a peroneal vein, leaving the patient without any arterial circulation. Some of the things that we've learned along the way, there are some factors that there are some factors that decide how much blood goes into the venous system. For those who are vascular surgeons who are dealing with fistulas, there's inflow pressure and there's outflow arterial pressure resistance, there's outflow venous resistance, and there is the distance between the crossover point that determines the amount of shunt that goes through. There's also the diameter of the shunt that determines the amount of volume flow that goes through the shunt. So what's the ideal location? We're on the cross in this case, about 3 centimeters or at least 3 centimeters below the lowest collateral, which is a peroneal artery in this case. Try not to cover existing collaterals as in this. Location of the crossover, patients with more extensive arterial disease, we tend to want to cross a little bit more distally to prevent a Steele syndrome. In this case, if you cross proximally, then you have a lot more shunting and you might actually steal from the native arterial circulation. Generally, if you do cross distally, then you might be leaving a vulnerable artery above, and that's usually treated with a drug-eluting stent. A case like that, using a off-the-shelf system of a 5mm Viaman and a 3mm artery, this is the graft infolding you get. At the same time, the diameter of the shunt increases the flow by up to 4 times, and you can be sure that this will get a Steele phenomenon. Inflow disease is a problem as well. If you shunt and create a fistula with existing inflow disease, then the only way that arterial flow will come in is from collaterals, and then you have a significant Steele syndrome. Venous anatomy, this we learned in the early days. It's pretty similar. There's a posterior circulation, there's a lateral plantar vein, there's a perforator, as in the arterial circulation. There's the anterior tibial vein, dorsalis pedis vein, and there's a medial marginal vein. These are the angiograms showing this. We've had the opportunity to do rotational angiograms, will give us a better appreciation of the way. There's usually a paired venous system. And with this, we were able to know where to land the wire. So selecting a good target vein, we avoid the anterior system due to a few things. The anterior system is usually very small. There is a flexor retinaculum that prevents the kinking, that leads to the kinking of the vessel. These vessels are also very small. However, the posterior circulation is a sump. It collects the blood from the whole patient, and it resides in the bottom half of the foot. And that's the reason why in patients who have DVT prophylaxis, they've got foot pumps, and that's to augment the blood flow in the lateral plantar vein to prevent DVT. So these veins are much more robust. On ultrasound, you can see them. There's a paired posterior tibial vein and a posterior tibial artery. To screen these patients, we usually do a Doppler ultrasound in transverse section. We follow these things all the way down to the lateral portion of the foot. You can see over here, we try to find a continuous vein that connects from the ankle all the way to the foot. And even after the procedure, we survey these and put them under color Doppler. We measure the volume flow, and we screen them all the way to the end of the foot. Post-procedural care, quite a lot to talk about, but we've had plenty of Doppler ultrasounds. We've had 22 patients with 623 volume flow measurements, and when we analyze this, the volume flow measurement mid-graft, which is mid-portion of the calf, of less than 195 mils a minute, not PSV, we run on volume flow like a fistula, was predictive of failure within the 3-month period. In these days, the typical volume flows you get from a procedure 1 week after the procedure run between 200 to 400. Anything more than 500 is probably not a good idea. And anything less than 100 is suggestive of a near impending occlusion, and we would re-intervene. An example like that, immediately after the procedure, 387 is pretty usual. 2.5 months later, that volume flow drops to 72. When we do an angiogram, we see stenosis at the distal end of the covered stent. We blow that with a drug-coated balloon. Immediately, you see that the volume flow pops right up to 280. And we can also see, actually, the TCPO2s jump up and down. Re-intervention is it's quite high, distal to the stent grafts, because some of these veins are also diseased. And if the volume flow drops in the outflow, we would also use drug-coated balloons and drug-eluting stents. Inflow, we would consider drug-eluting stents. Within the covered stent, there's no in-stent stenosis, as these are covered stents. And if the graft occludes, the usual lysis, angiojet, rotarex works very well, and after to unmask the lesion, which is usually in the distal portion of the circuit. As an example like that, a very critical stenosis, treated with a drug-coated balloon, with a superior stent in the early days. This was the scenario, but we did find that, for occlusions, we do a rotarex to clear the soft clot out, and we treat the outflow, and we get this kind of a result. So you can see that the TCPO2 measurements are also very reactive to patency. When the graft goes down and we resuscitate this, and the TCPO2 jumps back up again. So I think that's a useful way to give us an idea. This is actually the first patient treated with venous arterialization with the anterior circulation and the lateral plantar vein. Interesting, in this case, we had to reinforce these stent grafts with superior stents go across the ankle, but this is an angiogram. In 2 years' time, we can see certainly the vascular bed has remodeled quite significantly. These days, what do we do? Instead of a drug-coated balloon, we encourage negative or positive remodeling by putting a drug-eluting stent below the foot. We haven't had any stent fractures, as the stents are protected by the plantar fascia. This is a case with 2.5 years intervention pre-patency with a drug-eluting stent initially. Post-procedural focalization, this is what we call a flyby. This is partial arterialization. The blood goes back to the heart. We want the blood to go distally. This is ligation or tourniquet of the great saphenous vein. You can see that with the great saphenous vein occluded, you can see increased flow forward. And with the great saphenous vein ligation, you can see significant blood flow moving forward towards the foot. Embolization of collaterals is done quite frequent, usually about 6 weeks down the road. You can see in this case, this is usually a sign of success, where you see significant forward flow towards the foot. In a case like that, with the index procedure with coiling to prevent the blood from going back towards the heart, you can see an increased number of collaterals going towards the toe, and this culminated in wound healing without the loss of toes. Wound care and swelling, it's a complex case. Swelling is invariable. Wound care is different. We elevate the foot and we drop the foot as well. Antibiotics, because the number of stent grafts, we put plenty of antibiotics in for a prolonged period of time. In a normal diabetic patient, we get the blood pumping down, clear infection, debride the dead tissue. But in a DVA case, we don't debride aggressively. We do what we call active neglect. We give time for the vessel remodeling and granulation to grow. We never close flaps. We never do primary closure. And we use negative pressure therapy at low pressures. Sorry, in summary, there's a lot to learn. Every case is a learning case. Thank you.